All right, thank you, everyone. It's 38 minutes after the hour. I wanted to thank our presenters again from the last meeting and reconvene this session, which will include two topics. First, we will have Dr. Sarah Long, chair of the RSV vaccines work group, to provide an update to the committee on RSV vaccines. So Dr. Long, as soon as your slides go up, the floor is yours.
Thank you so much, Dr. Lee. I'm honored to be able to introduce to the committee the newly formed Maternal Pediatric Respiratory Syncytial Virus work group, because there are products in the line for us to discuss. So that is good news indeed. Next slide, please. The reasons and purposes for the work group are because RSV is a major cause of lower respiratory illness, particularly among young infants and children, and probably less appreciated also among older adults and adults with chronic medical conditions. RSV vaccine and monoclonal antibody development has progressed in the past decade, with over 40 candidate vaccines and monoclonal antibodies currently in development. The target populations for whom these products are intended include infants and young children, pregnant women, and older adults. Next slide, please. It was the CDC's decision to make two work groups. The one that I chair and I'm talking about right now is the Maternal and Pediatric RSV work group that will consider products that will target protection of children. A different work group will look at elder adults as well as immunocompromised. And we plan to review the epidemiology and burden of RSV disease in children and pregnant women, review the efficacy, immunogenicity, safety, and cost effectiveness of RSV vaccines and newly developed monoclonal antibody products in pregnant women and children, and provide evidence-based recommendations regarding use of these products in pregnant women and children. We also intend to identify areas in need of further research for informing potential future vaccine and monoclonal antibody recommendations. Next slide, please. So here is a snapshot of the products that are FDA approved or in development. And you'll see in the left-hand margin, there are 4 strategies for vaccine development, and in the 5th column on the left is immunoprophylaxis. And if you look over to the far right lower panel, you'll see that the only approved product is a monoclonal antibody, palivizumab, which is costly, is given in 5 doses, and has only modest benefit in even preventing hospitalizations. It has been available since 1998. The kinds of vaccines that are under study include the gamut, live attenuated, protein-based nucleic acid vaccines, and recombinant vector vaccines. And we'll now focus on those that are in phase 3 or later trial. Next slide, please. And you'll see that they're marked with either E's or M's or P's. E is for the elderly. That means that's the targeted population of the manufacturer and the intended first biologic license application. M is for maternal immunization. That would be akin to Tdap vaccine for pregnant women. That would raise antibody that would cross the placenta and protect the offspring for the first, hopefully 6 months, vulnerable months of life. And then the pediatric preparations, interestingly, are not vaccines, but are the monoclonal antibodies. So we anticipate that we will have a vaccine and then a monoclonal antibody and then another vaccine come to BLA application within the next 12 to 16 months. Next slide, please. The work group members include 2 other members of ACIP, a very elite group of content experts, the consultants, the liaisons that are very critical from the stakeholders that would be involved with maternal vaccine and protection of infants. very importantly, including the American Academy of Pediatrics, that for the last 20 years has been the group that has recommended use of palivizumab. And our fearless leader at CDC, Jefferson Jones, who's the captain of our ship, and many, many individuals at the CDC who lend their expertise. And we are delighted to have the CDC involved with both vaccine and monoclonal antibodies in this regard because of the resources that the CDC can bring to evaluating models, cost effectiveness, et cetera. Next slide, please. So we have had a few work group calls, October through January, reviewed the burden of epidemiology of RSV, reviewed the U.S. surveillance systems and definitions of infection and disease, and began to discuss potential components of cost-effectiveness considerations for RSV vaccines and monoclonal products. Next. Upcoming activities will be to review the safety and efficacy with manufacturers of the developing vaccines and monoclonal antibodies, to review seasonality data in relation to potential recommendations for timing of administration of either of these types of products, and review results of cost-effectiveness models. We'll present the data to the ACIP. We will then apply evidence to recommendations framework for each product, and we anticipate that the first vote by ACIP is not expected until 2023. Next slide, please. So that is what this slide reminds me to thank all those who've already contributed immeasurably to the deliberations on this important topic, and to transmit our excitement and also the challenges that we already know that we will face in considering these two very different kinds of products. Thank you, and I turn it back to you, Dr. Lee.
Thank you, Dr. Long, and I will add my enthusiasm for the year 2023 when this becomes a possibility. This presentation, if it's okay with you, Dr. Long, I'd like to ask if there's any questions from our members or liaisons or comments quickly before we move on to the next section. Okay, I don't see any hands. Oh, Dr. Chen, please go ahead.
Very briefly, and thank you, Sarah. That was, Dr. Long, that was a wonderful introduction to what I think is going to be an exciting set of discussions for the future. It's been a, very long hindered area. The past summer that we experienced, we had an unusual RSV surge, and I wonder how that is being discussed within the work group as far as what we thought was the epidemiology during the coldest parts of the seasons and what we observed last year. Of course, these are COVID times, but I don't know if that also was a topic of the discussion for just the epidemiology, simple understanding of this virus.
Yes, I think that I don't have any answers for you, and we haven't specifically discussed the potential reasons for this very aberrant season. I think as far as our deliberations for use of products go, the next 12 months will be very important to see if RSV does revert back to its more typical epidemiology or not. But all of that will definitely affect recommendations, as these will be birth month of the year and time until 6 months of age. All of that will be very important, how it coincides or does not coincide with an RSV season. So important questions.
Thank you. And I don't see any additional hands raised, so we will move on to the next session, which is our next part of the session. First, Dr. Kathy Paling, chair of the Pneumococcal work group, will introduce this particular section. Dr. Paling, please go ahead.
Okay, thank you very much. We wanted to follow up our previous conversation on pneumococcal vaccines, so next section. This is a reminder of, and a special thanks to all of our pneumococcal vaccine work group, ex officio liaisons, and consultants who've given so much to this work group. We do want to highlight and say a special thanks to Dr. Kip Talbot for her contributions to the work group, and recognizing that she has so much on her plate that she is going to be transitioning off. And a special thanks to Dr. Mawako Kobayashi, who's been our fearless leader. Next. And a special thanks also to our CDC contributors and to our grade and ETR consultants. Next slide, please. This is a reminder of the pneumococcal vaccine work group terms of reference. Next slide. And the purpose of this is really to follow up on the October 2021 ACIP vote on the use of PCV 15 and 20. Because we said we were going to work on clinical considerations and follow-up. This is the follow-up. So adults aged greater than 65 who had not previously received a pneumococcal conjugate vaccine or whose previous vaccine history is unknown should receive a dose of pneumococcal conjugate vaccine, either PCV20 or PCV15. When PCV15 is used, it should be followed by a dose of PPSV23. That was the vote. All right, next slide. We also voted on adults 19 to 64 years of age with certain underlying medical conditions or other risk factors who have not previously received a pneumococcal conjugate vaccine or whose previous vaccination history is unknown should receive a dose of pneumococcal conjugate vaccine, either PCV20 or PCV15. When PCV15 is used, it should be followed by a dose of PPSV23. Next slide, please. And so remember, the anticipated licensure for children, which is what much of the work group is focused on, is for PCV15 is expected to be in Q1, Q2 22. So we're on a fast track. And then for PCV20, licensure is anticipated in Q2 to 3. Next slide, please. All right. Thank you.
Right. Thank you, Dr. Kobayashi.
Thank you, Dr. Paling. Excuse me. Thank you, Dr. Lee and Dr. Paling. So next slide, please. As Dr. Paling mentioned just now, at the October ACIP meeting, the ACIP voted on use of the 15-valent conjugate vaccine, PCV15, or the 20-valent pneumococcal conjugate vaccine, PCV20 for U.S. adults. And the language that was voted on focused on adults who have not previously received the pneumococcal conjugate vaccine or whose previous vaccination history is unknown. And again, as Dr. Paling mentioned, I will share additional guidance that we proposed that was not part of the vote. Next slide, please. This is the clinical guidance for the recommended interval between PCV15 and the 23-valent pneumococcal polysaccharide vaccine, PPSV23, for those who receive PCV15. When PCV15 is used, the recommended interval between PCV15 and PPSV23 is at least 1 year. A minimum interval of 8 weeks can be considered for adults with an immunocompromising condition, cochlear implant, or cerebrospinal fluid leak to minimize the risk for invasive pneumococcal disease caused by serotypes unique to PPSV23 in these vulnerable groups. Next slide, please. This is the clinical guidance for those who previously received PPSV23 only. Adults who have only received PPSV23 may receive a pneumococcal conjugate vaccine, either PCV20 or PCV15, at least 1 year after their last PPSV23 dose. Next slide, please. Regarding the clinical guidance for those who previously received PCV13, either with or without PPSV23, these were the considerations. The work group is in favor of providing an opportunity to administer higher valent pneumococcal conjugate vaccines to those who have already received PCV13 with or without PPSV23. However, the incremental public health benefits of providing PCV15 or PCV20 to adults who have received PCV13 only or both PCV13 and PPSV23 have not been evaluated by the ACIP. Therefore, the MMWR policy note expected to be published on January 28th does not include a recommendation on PCV15 or PCV20 use in adults who previously received PCV13 with or without PPSV23, but will allow adults who are pneumococcal conjugate vaccine naive to have access to the new vaccines. We plan to conduct an evaluation on higher valent pneumococcal conjugate vaccines for adults who previously received PCV13 for consideration by the ACIP in the future. Next slide, please. Therefore, the proposed language for clinical guidance for adults who received PCV13 with or without PPSV23 is as follows. The incremental public health benefits of providing PCV15 or PCV20 to adults who have received PCV13 only or received both PCV13 and PPSV23 have not been evaluated. These adults should complete the previously recommended PPSV23 series. Next slide, please. As Dr. Taylor mentioned, the work group has started reviewing data on PCV15 use in children, anticipating FDA licensure of PCV15 for children as early as April of 2022. PCV20 licensure is anticipated in 2023. Next slide, please. Currently, PCV13 is recommended for the following groups of children: routine administration for all children aged under 2 years, catch-up vaccination for children aged under 5 years who missed their recommended doses, children aged 2 to 18 years with certain medical conditions in series with PPSV23. Next slide, please. This is the policy question that is being considered by the work group. Should PCV15 be recommended as an option for U.S. children who are recommended to receive PCV13? Next slide, please. In the months leading to the vote, the pneumococcal work group plans to review the following pieces of evidence: immunogenicity and safety on PCV15 use in children, epidemiology of pneumococcal disease and vaccine preventable disease burden for invasive pneumococcal disease and non-invasive pneumococcal disease, expected public health impact and cost effectiveness of PCV15 use, and we will use grade and evidence to recommendations framework to summarize the evidence. Next slide, please. At the February ACIP meeting, we plan to present data on pediatric pneumococcal disease epidemiology, findings from phase 2 and 3 PCV15 studies in children, and part of the workgroup interpretation of the evidence to recommendations framework and grade. At the June ACIP meeting, we plan to present a summary of the cost effectiveness analysis and the remainder of evidence to recommendations framework. We plan to have an ACIP vote on recommendations for use of PCV15 in children after expected licensure and when deemed appropriate by ACIP. Next slide, please. Thank you very much, and I would be happy to take any questions. Thank you.
Thank you, Dr. Kobayashi. This presentation is now open for questions. Dr. Cotton?
Thanks. So what will come out in the MMWR if there's no recommendation for people that previously had a conjugate vaccine? Then that people are left with a lot of questions and not clear if they should be giving or shouldn't be giving. So is it possible to have some clarity there?
Thank you for the question. Could you go to slide 13, please? So because of the fact that we have not had the opportunity to review data and present data on use of the higher valent conjugate vaccines to ACIP yet for consideration for a vote, this is the language that we are currently planning to include in the MMWR that is upcoming in at the end of the month.
Okay, and what Okay, so it'll just be left, and no matter when, even if they had PCV13 5 years or earlier, this is just how it's going to be for them for now.
For now, that is correct.
Thank you.
Dr. Paling?
Thank you, and thank you, Dr. Cotton, for this question. I think it's important to review the history of how we got into this position. The work group worked hard to simplify the pneumococcal recommendations, recognizing that a simplified recommendations would increase coverage and equity. And we also worked hard to get a timely vote after the licensure. During the October 21 ACIP meeting, it was mentioned by multiple persons, and we talked about immunocompromised and elderly. At that time, these conversations were truncated with and told that should be under clinical considerations. It was understood that the work group could fill in the gaps on some of these questions and include that in clinical considerations. As you may recall, this ACIP meeting was jam-packed. We were on a tight schedule, and there were lots and lots of votes. The work group after this meeting met and recommended clinical considerations. In the review process, it became clear that the vote language was more restrictive than intended. The work group met yesterday and unanimously felt that enabling access to newer pneumococcal conjugate vaccines is important for immunocompromised, high risk, and elderly, and that the proposed language creates clinical barriers and decreases both access and equity. At the same time, we recognize there are lots of naive persons that need this vaccine. So moving forward, we propose that we quickly evaluate, find the data available, and come back and present to the ACIP to fill in this gap. And with that, I would love input on any specific data that we would need to include in such a presentation. Thank you.
Thank you, Dr. Paling. I see 2 liaison hands raised. I just wanted to clarify. I think this was Dr. Cotton's question. I just want to clarify, Dr. Cotton. When I look at this, there is a distinction in my mind between people who have received PCV13 only, and I am coming at this from a pediatric perspective where we have to think about these immunization schedules for the immunocompromised in particular. If they are due for their PPSV23, should they get a polysaccharide vaccine or should they get a conjugate as the sort of boost in that instance? That might be a little bit of a different question than people who have already gotten PCV13 and PPSV23. So Dr. Paling, are you thinking about those the same or differently?
We have talked about all of those, but we've been told that we can't make a move with what's been presented yet.
Okay, thank you. Dr. Goldman?
Thank you, Jason Goldman, American College of Physicians. If I'm speaking as an individual practicing internist, I have several concerns with this policy of not allowing for an additional pneumonia dosage of the new conjugate vaccines to those who have been previously vaccinated for 3 quick reasons. The first, the best interest of the patient. The second, logistical issues. And the third is the confusion that this will create in messaging with the policy. As an internist and primary care physician, the most important patient is the one right in front of me. And while public health and resource concerns are necessary, I am more interested in what is most beneficial to that patient. Many patients have received either PCV13 with or without PPSV23, may have received them at such a significant interval in the past that they're aging into a category for an additional dosage, or are facing immunosenescence and are left unprotected at an older age, reinforcing the need for repeat vaccination. I do not believe it is in the best interest of the patient not to offer them an additional conjugate vaccine that will allow for additional protection. This is a case where the harms are minimal, the vaccine is safe and effective, and this is a scenario where permissive or shared clinical decision-making is appropriate. Second, many healthcare systems and physicians may have chosen a path to only give PCV20 over the 15-23 combination, and to now suggest that they have to go back to an additional dose of 23 may create impossible tasks of acquiring and stocking multiple vaccines, and the patients will not be able to get fully protected. It is similar to when ACIP decided to allow for Tdap to be interchangeable with TD and therefore allow only one vaccine to be able to be stocked. Third, the previous confusion created by multiple schedule changes with pneumonia made it difficult for frontline physicians to implement, and the hope was this new vaccine schedule would keep it simple and allow for better uptake of the vaccine. I encourage the committee to allow for an additional dose of conjugate vaccine to those who have previously had PCV13 with or without PPSV23, with either a permissive recommendation such as may give or a shared clinical decision-making, as I believe this will allow for improved protection against pneumonia, reduce the individual risk of disease, and save lives. Thank you.
Thank you, Dr. Goldman. We'll move to Dr. Long.
Yes, I think considering the unanimous decision, unanimous wish of the work group was that this not be put in the MMWR. And with Dr. Paling's statement that she's willing to do the hard work to try to bring this to the ACIP in just a month's time, a little over a month's time, I would very much be in favor of not putting a statement at all about this situation of those who are not previously naive for one more month until we are able to look at the data more carefully, because we all felt that this was the wrong direction to continue these individuals on PPSV23 route when we have PCV20. And we have said for those who are naive, they could either get PCV15 or PCV20, and if they got 15, they should 15. It should be followed by PPSV23. So I don't know how this is different from that, except that there would be nobody who would want to then give someone who'd received 13 PCV15 followed by 23. So what we think would make the most sense and would restore really the understanding and the faith of practitioners in the pneumococcal vaccine recommendations would be to give flexibility to use either 20 or PPSV23 in those who previously had received PCV13.
Thank you. Dr. Cotton?
I just wanted to say that I agree with the comments from Drs. Goldman and Long, and I really think we should have flexibility and clarity here. Already, the majority of clinicians that I meet with don't really understand the recommendations that were made years ago now for PPSV23 and PCV13. When I bring up 15 and 20, they find further confusion, and this, there is safety data to suggest that there really would not be harm in giving additional doses of conjugate vaccine. And so I agree with the comments about flexibility. We know from surveys and whatnot that many Americans who are at high risk for pneumococcal disease remain ill protected. And I don't think we should increase barriers towards providing protection, but rather provide clinician flexibility and significant clarity in guidelines. So, thank you.
Thank you. Dr. Freihofer?
Sandra Freihofer, American Medical Association, but speaking as a practicing physician, I applaud the work group and ACIP for simplifying this pneumococcal recommendation because we now have the higher valent conjugate vaccines. But I wanted to, and I think this will be much easier to implement and much easier to explain to those administering these vaccines. But But I wanted to clarify, there's no reason now for anyone to get more than one PPSB 23 from here on out. Is that correct?
Hi, this is Dr. Kobayashi. So, Dr. Freihofer, are you referring to based on the new recommendation, the conjugate vaccine, the higher valent conjugate vaccine?
Yes. Before, there were some groups of patients that would get another dose of PPSB 23 once they turned 65, if it had been at least 5 years since they had had a PPSB 23. So the way I'm interpreting what has been written so far is there would be that the need for an additional PPSB 23 would be out, correct?
That is correct. So currently, under the new recommendation, people who receive PCV15, we are not recommending repeated doses of polysaccharide vaccine at this point. However, for those who received PCV13, this language is referring them to the existing recommendation. So if they're due for, what that means is if they're due for another polysaccharide vaccine, then that's what they'll get.
I am so glad I asked this question because from what I'd heard in the presentation, that wasn't clear to me. Thank you so much.
Thank you. Dr. Zimmerman? Oh, actually, let me pause for a second. Dr. Posner, did you want to chime in?
Thank you, Dr. Lee. I think this is a very important discussion that we have to have, and we have to be making recommendations based on the evidence that we reviewed. And I think that what people have raised today highlights the importance of moving quickly to review the evidence so that we can adjust appropriately consider any changes to the recommendation.
Thank you so much. Dr. Zimmerman.
Yes, Richard Zimmerman speaking as an educator and practicing physician. I wanted to agree with Dr. Goldman and Dr. Long. I think the intent of the work group, which I've had a privilege to be on for many years, is the simple recommendation and to provide the flexibility. And so I hope we can resolve this quickly, as both of them mentioned. Thank you. Over.
Thank you, everyone. Are there any additional questions? One more hand raised. Dr. Hogue?
Thank you, Dr. Lee. This is Michael Hogue with the American Pharmacists Association. I just want to say that all that we publish that could potentially be then changed again in February is going to create confusion, no matter how clear we think we're being and how precise we think we're trying to be. So I just want to, as with my previous colleagues, support fully everything that Dr. Goldman said. I believe we need to give providers flexibility, allow them to use that flexibility, and we should be cautious about putting anything in print that could lead to just 30 days later, a month later, or whatever, additional confusion among providers and patients about how to use pneumococcal vaccines. I do applaud ACIP's simplification in the fall meeting. That's been well received, and we really appreciate that. Let's not complicate it by saying too much now.
Okay, thank you. Dr. Lair.
I'm understanding the position of several people. They're asking that the flexibility to give PCV20 if someone's had PCV13 alone or PCV13 plus PPSV23 in the past, they want to have the flexibility to give PCV20 now. I'm hearing people say that they want that flexibility. They'd also like to have this decision made quickly. My thought process is Dr. Paling has outlined a timeline, if I'm correct, that wouldn't have a vote until June. I'm just pointing out what I'm understanding from the conversation. I'm also saying that I'm not comfortable making that kind of decision without data. And so even though I hear Dr. Golding's strong recommendation to provide that flexibility, I wouldn't be in favor of it until someone laid out data in front of me. Thank you.
Thank you, Dr. Lair. And I believe that is the last hand raised for the moment. So what I'd like to do is thank our speakers today and for that discussion we just had. We will take a 2-minute break. So at 15 minutes after the hour, we will reconvene the meeting to begin oral public comment. Thank you, everyone.